Good afternoon and good morning to those on the West Coast. Welcome to today's webinar, State Strategies for Building Integrated Care Infrastructure. Thank you to all of you who are taking the time out of your busy schedules to spend part of your Friday with us. My name is Charles Townley and I'm a project director at the National Academy for State Health Policy. I will be today's moderator. Before we begin, I'd like to take this opportunity to thank the Commonwealth Fund for their support in this work. A few housekeeping items to keep in mind before we get started. Today's webinar is available through your computer speakers. If you encounter any audio problems during the webinar, you are also able to listen in using your phone by dialing 1-888-378-4398 and entering the conference ID 813455. Both slides and a recording of today's webinar will be available on NASHB's website within the next 2 or 3 business days. And as a reminder, all participant phone lines and microphones are muted, so please ask any questions using the chat box on your screen. Questions will be reserved for after the presentations, but we encourage you to submit your questions at any time. During today's webinar, participants will have the opportunity to engage with Kitty Parrington, a project director here at NASHB, as well as leaders from Idaho and Minnesota. After Kitty provides an overview of state strategies, we'll hear from Matt Wimmer and Jennifer Blanchard. Matt Wimmer is the administrator of the Division of Medicaid for the Idaho Department of Health and Welfare. Jennifer is Director of Community and Care Integration Reform for the Health Care and Community Supports Administrations at the Minnesota Department of Human Services. Following the presentations, we'll open up the discussion to Q&A. Without further ado, Kitty, the floor is yours.
Hi, good afternoon and good morning for folks on the West Coast. Thank you, Charles. I am very pleased to be talking today about a new brief from NASHB on physical and behavioral health integration. This one focused on defining key infrastructure and state approaches to support that infrastructure. So for this brief, NASHB reviewed the emerging consensus across a number of prominent integrated care models and approaches. And from this review, we identified some common components of integrated care infrastructure. And then we looked at how leading states are supporting this infrastructure through a number of different policy strategies. So this brief came about as a result of our engagement with states as part of our Commonwealth Fund Learning Collaborative, and also other research and conversations we have had with state policymakers engaged in this integrated care work. We know it is a very important issue for states, and that people with both behavioral health and physical health care diagnoses are some of the costliest enrollees for state Medicaid programs. We also know that recent major reform efforts, including the State Innovation Model Initiatives, DSRIP 1115 waivers, and implementation of health homes, have had integrated care really part and parcel of their efforts as an important strategy for states. And while there are many models and approaches and kind of frameworks to look to gauge integrated care out there, we did hear from states that they were still sometimes struggling with what exactly integrated care should look like from a state policy perspective. And I think part of this is because states have a unique perspective on these issues, and they need to be thinking about not only a specific evidence-based model, but also diverse settings and populations, and they need to be thinking systemically. And for this, they may want to look at an adaptable, functional approach that could help them build capacity, regardless of a setting or system configuration. So we looked at a number of prominent approaches, and these approaches were developed for various audiences and really for very diverse purposes. So they're by no means represent specific models necessarily or things like that, but really they are well-respected work in the integrated care field. So we looked at the 2014 National Committee for Quality Assurance Patient-Centered Medical Home Standards, which has introduced new or expanded integrated care concepts. We looked at ARC's lexicon for behavioral health and primary care, which speaks to a definition for integrated care in primary care settings. We looked at Medicaid health homes and the required elements for Medicaid health homes. And we also looked at the collaborative care core principles. The collaborative care model is a prominent integrated care model with a wealth of research that speaks to its efficacy. And what we found across these diverse pieces of work were some common themes about what the key components and sort of building blocks from a functional perspective are for integrated care. And these include multidisciplinary teams, a systematic approach to care using population-based tools, clinical guidelines, and or evidence-based practices. A key functional component is also care management or care coordination, including some attention to care transitions, and also the use of health information technology and quality measurement and improvement techniques. And while these definitions varied, these pieces of the puzzle, these functions were really present and consistent across all of the approaches that we reviewed. So I'm just going to talk very briefly and at a pretty high level about the state's strategies that we're seeing to support these pieces of infrastructure. And this is also fleshed out in more detail in the NASHB brief, which is available on the website. So we looked at how states engaged in health reform or health system transformation efforts were working to support the various functional areas for integrated care. And certainly leveraging Medicaid is a key policy component to all of these integrated care efforts for states. And in particular, Medicaid is useful in supporting the service-related components, such as supporting that team-based care component, making sure that individuals have access to care management or care coordination, and that is part of the approach or model, and also supporting the capacity to do some population-based healthcare strategies. This slide identifies very briefly and at a pretty high level some of the options available to states to support these service components within their Medicaid systems. And I think the message here is really that there are a lot of ways to do this, from very broad 1115 waivers to specific state plan options. And of course, these decisions are very highly dependent on the state context, state priorities, the target population, state-managed care configuration, and other factors. But I think the takeaway is that Medicaid offers substantial flexibility to support care management, to support population health strategies, and to support team-based care. Certainly, health homes have become a very important vehicle for creating new provider configurations that support these core components of integrated care. We're also seeing 1115 DSRIP initiatives that increasingly are being used to drive major system transformation that also includes integrated care, such as in states like New York and New Hampshire, for instance. And we'll hear more from Idaho about some of the work that they're doing in this area. But states can also use state plan options such as PCCM and rehabilitative services to build some of the pieces of this infrastructure. So again, there's many ways to, there's many access points in Medicaid to support these various components. Another provider strategy that, or another state strategy rather, that we're seeing is the is building some of these core components into provider requirements. So again, health homes and behavioral health homes have very often have very specific language that serves as a blueprint, as sort of the state blueprint for these integrated care models. States may also incorporate 2014 PCMH standards into programs, primary care programs as a condition of participation. and primary care practices then typically receive an incentive payment for meeting specific standards for building that core infrastructure. State DSRIP initiatives can also contain some pretty detailed descriptions about how states want their systems and providers to operate as integrated care entities. And this can include the content and detail around integrated assessments that are including both behavioral and physical healthcare components to composition of care teams. So states are really starting to offer a very detailed picture of how these core components should be operationalized at the provider level. States are also looking at training and workforce development as another important tool. Certainly, we're seeing state policymakers increasingly engaged in standing up learning collaboratives and training resources for their provider communities to really translate the knowledge and the vision of the state's integrated care work to providers. In terms of Oregon developing through its STEM transformation hub. Other states, as I say, have stood up learning collaboratives for both primary care and behavioral health practices to move their systems towards integration. New workforce is another piece of the puzzle for many states, such as community care teams, integrated peer models, and psychiatric consultation. States are also starting to look at how they define and limit services in various settings to identify unnecessary barriers to integrated care. A major piece of work for states, particularly states that are engaged in state innovation model initiatives, is building data infrastructure for behavioral health, which, as we discussed previously, is another core component of integrated care. And states are really taking a leadership role in developing this kind of data capacity. They are providing guidance, including very specific use cases for behavioral health providers, funding behavioral health provider connections to the state HIE. States are developing and pushing out population-based integrated data tools for use in integrated care settings so that providers have both behavioral health and physical health information at their fingertips. States are facilitating exchange through universal consent forms and other forms of technical assistance around privacy, HIPAA, and 42 CFR Part 2, and also supporting direct technology for, in particular, behavioral health providers who may not have access to high-tech funding, have not been able to fully operationalize an EHR, and are using direct technology for transfer of information. Just a couple of other leverage points that we note in our brief. State policymakers are also starting to look internally to think about how their state systems are configured and constructed to support integrated care, looking at licensing requirements, trying to breach some of those silos across mental health, substance use disorders, and physical health to unify licensing requirements and support providers in delivery of integrated care, and starting to look at doing broad reviews of licensing. For instance, Arizona has done some significant work in reviewing its licensure and regulatory framework to specifically support integrated care. Managed care contracting is another place where we're seeing states start to embed integrated care language, and again, another opportunity for states to really articulate their vision of integrated care, how they would like providers to communicate, how they would like these teams to look, and how they hope to deliver integrated care, what kinds of settings, what kinds of populations they are looking at. So that's becoming another important vehicle for states to articulate that information. So I think that's it, and I'm going to pass it back to Charles. Thank you very much, Charles.
Thank you, Kitty. And at this time, I will invite Matt to give his presentation.
Thank you, Charles. Can everyone hear me? This is Matt Wimmer. I'm with Idaho Medicaid, and I'm going to talk a little bit about the efforts that we've made towards behavioral health integration, and specifically around how we've implemented that in our primary care case management system. Next slide. Our foundation for all of this is our Healthy Connections program, and so this is our primary care program that we have had for many years. It was established in 1993 and has kind of gone through a number of evolutions. It has always had a focus on care management, and has always had some recognition of the importance of care transitions. We're fortunate in that we have very good access to the primary care providers in our state. We've got over 90% of all of the providers statewide, and traditionally have had that. So we're starting from a good point from that. Now, moving on to the next slide, there are some downsides as well with this. In the past, this was very much a gatekeeper approach, as you might expect from when it was implemented. We've had a really heavy focus on referral requirements, and had used it as really kind of a enforcement or control technique, I guess you could say, for whatever service there was on offer, and kind of had tried to run all of that through the primary care provider. The providers were very focused on the fee-for-service payments and the methods of attribution, so that they could tell whose patients were theirs and be really clear on what all the referral requirements were. And so it was kind of focused in that way in the past. Next slide. Over the years, though, probably in about the past 10 years or so, we've really started to move away from that kind of model where it's really just a gatekeeper model and more towards a patient-centered medical home model. So we had our community health centers participate in the Safety Net Medical Home Initiative back in 2008. That was with the Commonwealth Fund and Qualis Health, and that really set a good base for this. We had our governor issue an executive order for the Idaho Medical Home Collaborative in 2010, and our governor has been very supportive of all the efforts that are directed towards patient-centered medical homes, and so that's been helpful. We worked with primary care practices under that executive order, and that with the passage of the ACA and the authorization of the Health Homes program, we authorized health homes in Idaho in 2014. And that was primarily focused on chronically ill, including people with behavioral health needs, although most of the focus was more on the physical health end of the spectrum. In 2015, we got our SHIP grant. This is a State Innovation Model grant that was really focused around changing payer approaches to value-based purchasing and patient-centered medical home type approaches in particular. And in 2016, we implemented our patient-centered medical home incentive program, which I'm going to tell you more about on the next slide. So part of that, overall, what we did with that is we established 4 different tiers of reimbursement. So a primary care practice, depending on their level of patient-centered medical home capabilities, could receive additional reimbursement on top of their fee-for-service in the form of a per member per month payment. And that varied depending on what those capabilities were. We wanted to address behavioral health integration as part of that, and so we built in a behavioral health integration option. And to qualify for that, you needed to have a co-located or highly integrated model of behavioral and physical health care delivery. We used the SAMHSA Integrated Practice Assessment tool as a guide for that qualification. This was one of a number of options. We kind of threw a lot against the wall and to see what would stick, and I'm happy to say this is one of the ones that did. But this was one of several options that you could use to get into that higher tier. This is in Tier 3 out of 4, and get increased reimbursement for and it's actually fairly substantial. It's a jump of $4 PM from the next lower tier, and that is the biggest jump in this entire tier structure. We had some NASHP technical assistance along the way in implementing this, and that was outstanding and very helpful. Next slide. So we put that out there when we really weren't sure what kind of reaction we would get from providers. We were hopeful. We knew we had a few practices out there that were pursuing integrated models, and I would say we had a good response. It wasn't overwhelming, but we're happy with what we did get. So we have 7 locations currently participating in Tier 3 under that behavioral health integration pathway. We have 3 of St. Luke's hospital clinics, which is here in the Boise area and the Treasure Valley. And then we have 4 Valley Medical Center locations in north central Idaho. They both have integrated electronic health records. They have processes for screening. They have all the types of things that you would expect from an integrated behavioral health and primary care provider. And they serve about 14,000 patients through those clinics, through those 7 clinics. In addition to those, our community health centers have, some of them, Terry Riley in particular, and family medicine residency, have had a long focus and kind of a deep effort on behavioral health integration. And so there are 23 locations that are participating in Tier 4, mainly from those community health centers. And many of those have an integrated program. They care for about 20,000 patients. They're also NCQA recognized as a patient-centered medical home, and they get an even higher level of reimbursement in addition to their fee-for-service of $9.50 to $10 PM, depending on patient characteristics, very broadly specified. Next slide. So the funding strategy that we used for this, this is all authorized using primary care case management authority. So, and that's the same authority we've used all along, even way back since 1993, although it was under 1915B then. We did use that Health Homes Authority, and we used that just for a couple of years, and then transitioned that to a single authority under the primary care case management. Enrollment in primary care case management is mandatory for most Medicaid participants. There are some exemptions, and these are federally driven. Dual eligibles, Indians, children with special health care needs, all of those people may opt out if they so desire. Not too many of them do, and we have over 92% of our population that is enrolled in our Healthy Connections program. And the ones that are not enrolled are mainly people being served through institutional care or that have opted out for another reason. They all have to have a choice of primary care providers, and there is one very extremely frontier part of the state where there is only one primary care provider around, and so it's not mandatory in that area. But we affected all of these changes through state regulations, state plan amendments, and updates to provider agreements. We didn't need to go into any kind of waiver scenario, and CMS has been fairly supportive of our approach as we moved through this. It was, I won't say it was simple or easy, but it wasn't onerous either. Next slide. As far as the support that we provide to the clinics, we do have representatives that go out to the primary care practices, and they try and visit each location twice a year. They provide significant training and support to those clinics, and they're always available via phone. One of our staff has previous behavioral health background, and so that's been helpful as we implemented this option. We also made some concurrent changes to our telehealth policy to support reimbursement for telepsychiatry, and our behavioral health managed care contractor made some changes at the same time as well to expand that and allow for more telepsychiatry reimbursement. that, we were hopeful that that would really drive a lot of change, but we haven't seen a big uptick in the telepsychiatry, and I think that's, maybe for a number of factors, and if folks have questions about that, I can try and speak to it. Next slide. So our future plans, we're currently working to implement a provider dashboard for all of our primary care providers. And so what that will do is it will show performance metrics for a number of measures. I've called out the ones here that are behavioral health focused. So acute phase depression therapy, follow-up post-discharge on mental health inpatient episodes, ADHD treatment initiation, and we specifically chose those metrics because we wanted to continue to promote some behavioral health integration. And so those will be displayed to all primary care providers, whether they're participating in this piece of it or not. And we're looking at that happening towards the end of this year, sometime fall, winter timeframe, so that they will be able to see how they're doing as compared to the rest of the state. We are also planning on implementing, probably sometime early in 2018, an expansion of this whole entire structure that I've been speaking of that will allow for some shared savings. So primary care practices that want to participate will be able to, if they meet benchmarks on quality measures, they'll be able to share some savings based off of the experience of the patients that they care for and their utilization of services. We're also concurrent, so that's on the primary care side of things. We're also doing kind of an accountable care type concept and with regional care organizations that are going to be optional for primary care practices to participate in, but there's an even bigger opportunity for them there, and if folks are interested, I can tell more about that. The Idaho Primary Care Association has done a lot of work over the years in this direction, and they have created a network community health clinics network of Idaho and their tentative plan is that they will enter this as a network and that they will participate and be able to access shared savings as a network. We're still meeting and talking with them and talking about strategies to expand integrated approaches to care, because I think there's some really good opportunities there. They've got some outstanding providers and some outstanding approaches to care that we're hopeful we can leverage. So that is a little about what we have done and a little about what we plan to do. And the next slide has just my contact information if any of you want to shoot me an email or give me a phone call.
Thank you so much, Matt. Definitely appreciate all of that information, and just want to mention again that if anyone has any questions for either Kitty or Matt, please submit them at this time or anytime before the webinar ends. We are holding them until the end, but we certainly will get to them, time permitting. And just another quick reminder that the slides and the recording of today's presentations will be available on NASHB's website next week. If you do not see the chat box on your screen, you may need to exit full screen view, and I believe it's in the bottom left corner of your screen. So with that, Jennifer, would you like to start?
Yes, absolutely. Thank you. I appreciate the opportunity to share with you some of our state's approaches to supporting and promoting the development of integrated care infrastructure in Minnesota. In my role, I have had the pleasure to lead the development and implementation of our state's health home model, while at the same time overseeing our state's State Innovation Model Grant, which we administer jointly with our state's Department of Health. And today I'm going to focus a little bit about how we defined our guiding principles of our health home model and how they have supported the use of some of these key components in supporting further integrated care in our state. And I'll also talk briefly about how we leveraged the SIM initiative to support providers in building the infrastructure necessary to do integrated care. When our state decided to move forward with the health home opportunity, one of our biggest challenges, quite frankly, was developing a model that fit within our already robust and sometimes complicated set of case management and care coordination services we have. For instance, we have had a very successful patient-centered medical home model, healthcare homes in Minnesota since 2010, with well over 65% of all primary care providers participating in that model. We have had a long-standing relationship with our managed care organizations, which have many robust care coordination service delivery models offered to seniors and disabled populations. And we have numerous targeted case management and waiver case management services available to individuals receiving Medicaid. Our decision to focus on the development of a behavioral health home services model really acknowledged the success of our healthcare home program, but recognized the unique needs of individuals on Medicaid living with serious mental illness and the need to design services that were more holistic and could be delivered where people were showing up regardless of the provider type. We believe there was a need for a framework that would allow varying provider types, regardless if they were primary care or behavioral health, to be at the center of providing care coordination, but most specifically doing so at a community-based level. Change slides. The framework was built to create some consistency in ensuring there were key components utilized that we knew supported the integration of care regardless of the provider type, while also allowing flexibility to deliver services based on the mission and values of the organization. That regardless of the provider type, we expected all behavioral health home service providers to deliver culturally appropriate, person-centered services. We expected all of them to build linkages to social services to ensure that individuals had the capacity to follow their care or treatment plans, that individuals receiving the services drove the way the team supported them in reaching their own health and wellness goals, and that there was a continuous quality improvement process in place informed by clinic level data, and then that there was a bar set for the use of HIT to support care coordination, population health management, and informing any quality improvement process. Change slides. Where there is flexibility is how a provider delivers services. Our behavioral health home model was designed in partnership with our mental health and healthcare administrations, which are both within the Department of Human Services, and we have also partnered and continue to work in partnership with our Department of Health, who oversee our healthcare home program. You know, my background is in social work and public policy, so when I took over the planning of this initiative, it was very clear that although I wasn't steeped in the language or the culture of either of these administrations, I could see that there was a real basic fundamental misunderstanding of basic language, and it was really impacting the way in which the planning was going. I would sit in early meetings, and although I wouldn't necessarily follow either group's perspective, I could easily see that there wasn't a shared value, and part of that, or a shared vision, in what we were trying to achieve, and it really was about that basic misunderstanding of one another's perspectives. So I encourage us to step back and go through a series of exercises to try to develop a common understanding of language and to develop a set of guiding principles that could come back to whenever our planning veered off course. I did use the National Integration Academy Council's lexicon for behavioral health and primary care integration, but interestingly enough, there wasn't a shared consensus that the terms reflected a mental health or social service background. So instead of agreeing to use those specific definitions, we agreed to honor and understand the definition based on each professional's background. The guiding principles in turn incorporated each professional perspective and helped the group see how our separate but equally important expectations of the service delivery model could be met. Next slide, please. We have 4 guiding principles. The first and foremost is that we felt strongly that there was a need for a multidisciplinary team with a shared caseload. That regardless of the model of integration, an in-home model or an in-house model, a co-located partnership model, or a facilitated referral model, that to demonstrate the true integration of these professional perspectives, you needed to have a multidisciplinary team. To be certified to deliver behavioral health home services, there must be a four-member team in place, really with the first being a team leader who acts as an administrative champion of integrated care and ensures that a culture of integration is supported in the organization. The second team member is an integration specialist, and depending on the provider type, is either an RN or a mental health professional. If the organization is a primary care setting, it is expected that an integration specialist is a mental health professional as defined in our state statute, and then conversely in a mental health setting, the integration specialist must be an RN. The third team member is a systems navigator who really is supposed to act as a central point of contact and deliver most of the behavioral health home services, and then the fourth team member being a qualified health home specialist. This position can be held by a variety of emerging professions such as a community health worker, peer support specialist, or community paramedic. That individual is expected to support individuals in meeting their health and wellness goals by acting as sort of boots on the ground so other team members can quote unquote work at the top of their license. Next slide. The second guiding principle in our delivery model is the opportunity to meet the needs of the individuals. Behavioral health home services are not about developing a care or treatment plan and doing the resource and referrals based on that, but instead it is about supporting an individual and identifying what they need to be able to achieve the objectives of any care or treatment plan developed by their primary care or mental health professionals they're working with. We have an expectation that providers do patient activation and use motivational interviewing to support individuals in their goal development. Next slide. A third guiding principle is the use of a strength-based perspective, which is really the origin of person-centered planning, the notion that an individual should drive the service model that works best for them and is based on their individual strengths and resources. Really, it's resiliency in action. Next slide. The final guiding principle is the expectations that providers deliver services with an ecological perspective. The expectation that relationships are built based on the understanding of the individual as a whole, their family, their culture, their community. Whole person care really is achieved when you take a holistic approach to understanding how the interacting systems of care, services, and supports impact an individual's overall well-being, recovery, and resiliency. Next slide. And these guiding principles helped us as we defined the 6 health home services and the expectations we put on providers regardless of their discipline. Next slide. The guiding principles are met in how the services are delivered. We have created a state-level certification process with a set of standards that need to be met regardless of provider type to ensure there is capacity to serve a population with serious mental illness and bring the guiding principles to life. For example, to ensure there's capacity to deliver integrated care, we develop infrastructure standards that require the use of a patient registry and electronic health record. We require providers to work in collaboration with a consumer's managed care plan, if applicable, and develop workflows in which both are held accountable to ensure better communication with one another. There are requirements for comprehensive assessment to ensure all domains of an individual's life are addressed in the delivery of service. We expect the delivery of and the facilitation of wellness and prevention education activities, some based on evidence-based curriculum, but at the same time supporting the use of peers in less formal ways of supporting health and wellness education. We also expect and support the utilization of the person's formal and informal supports. And as we close the first year of our delivery of behavioral health home services, we've been very happy with the number of providers who have come forward. We have 25 across the state, another 5 going through our certification process, and another 5 who have just come forward. And they include community mental health centers, large healthcare systems, children's mental health providers, and some of our FQHCs. And we utilize a per member per month payment structure with $350 per member per month for the first 6 months of the delivery of services and $245 per member per month thereafter. And we were really fortunate in our state to be able to develop our health home model while at the same time planning for and implementing our state innovation model, which we have coined as the Minnesota Accountable Health Model. It's through SIM that we have been able to really support providers in assessing their capacity and desire to do integrated care, and then at the same time providing the resources necessary to build that infrastructure once they decided to move forward with that. Our aim under SIM has been to accelerate new care delivery models and payment reform efforts already are underway in Minnesota in order to achieve a healthcare system that provides patient-centered coordinated care, holds providers accountable for cost and quality, aligns financial incentives to promote the triple name, and really implements collaborative approaches and achieves health improvement goals. And under SIM, our work is divided into 5 primary drivers, which you see in the next 2 slides. And really the key mechanisms we've used to execute our drivers have been through grants and contracts, technical assistance, and other resources pushed out to community and healthcare providers to ensure they have the capacity to provide integrated care. And very early on, we focused on ensuring that we were stacking grant opportunities and encouraging organizations to take advantage of and seek several of the funding and technical assistance opportunities. So for example, we have approximately 400 organizations that are involved in SIM-related funding in Minnesota, of which 37 organizations are participating in 3 or more SIM programs. Each of the opportunities under SIM include some practice transformation grants. We've been very fortunate to have 4 rounds where providers could request up to $30,000 as an example to develop workflows, IT infrastructure, staff development. Almost all of our first implementers of behavioral health home services sought funding under 3 or more of these rounds. Another example of what we were able to do through SIM was the development of practice facilitation. We brought in the National Council of Behavioral Health as one of the vendors to provide clinic level support to those preparing for behavioral health home services. We were able to bring on grants to support the emerging professions within behavioral health home service providers, the use of community health workers, community paramedics. We were also able to further develop a provider portal which can be utilized by our integrated health partnerships, which is our Medicaid ACO model in our state, our healthcare homes, and our behavioral health home service providers, which utilizes a outward-facing web-based platform where providers can come in and access reports that outline utilization claims and encounter data that they can use to better manage care. And as we move into the final 6 months of our SIM initiative, we can already see how the long-term infrastructure created in our state through SIM will really help us ensure sustainability of our integrated care models. So with that, I will pause and move into questions.
Great, thank you so much. So at this time, we will open up the floor to questions and answers. Just want to remind everybody that we will be accepting questions up until the end of the webinar. So as you think of your questions or as new questions arise, please continue to send them in. We will make sure to ask them. So we do have some questions on deck here. And the first, really want to kind of step back and think, and really learn more about how both Idaho and Minnesota came to realize the vision of what integrated care meant and looked like for your states. We know there's a lot of stakeholder engagement and a lot of providers and consumers at the table. Jennifer, you mentioned the use of the ARC lexicon, so thank you for that information. I'm just curious to learn more about, why those models, why those definitions, how they aligned with the state's vision, and then some advice potentially for states as they think about how to work through differences when, two provider groups do use a different language or might not see not eye to eye, but, if there's some, how to resolve those differences as they arise. Matt, I think I'll start with you.
Sure, and I think to speak to the first part of your question around working with stakeholders, I will say we were fortunate in that we kind of had a coalition of the willing with our community health care providers, our community health clinics. They were very engaged from the beginning. They, in a lot of ways, led this effort. And there's been a very strong partnership between the Division of Medicaid and the Primary Care Association over the years. So that was helpful. But I think also having the leadership support at the governor's office level also helped us. So that probably isn't particularly helpful to other states if you don't have that already. But those were two key pieces for us in bringing it together. Once we did have kind of a structure around it, the Idaho Medical Home Collaborative, we did get a lot of interest, and we did have not just those groups participating, but also community providers, and I think that group kind of served as a catalyst and helped move it forward. So I think that was some of the keys that we had. And Charles, could you repeat the second part of the question, because now I'm misremembering it?
Oh, no worries. It was a very long question, so my apologies for that. But just in terms of advice for your colleagues in other states, as these groups come together, how do you get everybody on the same page in terms of what integration, what everybody wants integration to look like?
We've struggled with that as well, because over the years we've done different efforts with groups, and we've run into situations where even where we had a primary care practice that was interested in collaborating, they didn't always get a warm reception from some of the behavioral health providers in the community. And so we're continuing to struggle with that to some degree. The ones that have been most successful have been the ones that have just said, we're going to own it. We're going to have behavioral health in our primary care clinic, and we're committed to just figuring out how to make that model work. We're trying to kind of foster more of that with our accountable care model, and we're trying to align incentives across the managed care plan and the primary care providers. So some of those same measures or one of those measures anyway, that we are going to be measuring for primary care providers, we are also planning on including as an incentive in our managed care contract, so that if there's better performance on that, so everybody's working towards the same goal, and that there's some incentive for the plan at least to work with their providers to try and build towards that. But it's very much a challenge that we have faced and haven't figured out entirely.
Great. Well, thank you. Jennifer, I don't want to make you repeat yourself in terms of what you already presented, but is there anything you'd like to add in terms of how Minnesota came to use the definitions and the model that were selected?
I think for us it was just acknowledging that each professional lens was going to have their own definition and perspective, and what population health means or what care coordination means is steeped in a lot of values, and there's a lot of emotion attached to that. And so really just owning that each perspective was important, is important, and having those shared goals is really what to work towards. And then honoring the value that each professional perspective brings, and that you really do need the varying provider types to truly do integrated care. And I think when we could really come to agreement on that, everyone could more easily see where they fit in the work, and then how collectively we could achieve our goals overall.
Great, thank you. So the next question, I'm curious to learn more about data sharing, particularly in between getting behavioral health providers either onboarded to the state's health information exchange, or just better connecting behavioral health providers into data systems to share allowable data, acknowledging any 42 CFR Part 2 issues. So could both of you speak to that conversation in your states and then strategies both to get behavioral health providers kind of more up to speed in terms of health information technology and making sure that they're not left behind in the work? And Jennifer, I think I'll start with you this time.
We are very fortunate that within at least our community mental health settings, most of our providers have had a decade of utilization of EHR. One of the main components of our work under SIM that has further supported a variety of different behavioral health providers is through our eHealth initiative, which is really led by and driven by our Department of Health. But under SIM, we actually spent a considerable amount of funds to develop a toolkit. Because not only are we dealing with national laws, we have a very specific state data practices law that adds complexity and confusion above and beyond the other two national rules. And so it really is a barrier to many, whether it's true or a perceived barrier to integrated care. And so that toolkit is just been produced. They did a phenomenal job of working with stakeholders across various provider types, social services, behavioral health, public health, and long-term supports and services, and did a year-long stakeholder work to really identify where there were barriers, where there was misunderstanding, the development of the toolkit, and then doing a series now of educational opportunities, webinars, trainings, toolkit materials available on the web to really help mitigate those. And so I think, that's sort of that broader piece of work, and then really trying to demonstrate and create tools for consumers so that they can drive and expect the sharing of information between providers has also been a very successful component of our work.
Great, thank you. And just two very quick follow-ups in terms of that toolkit. A, is it publicly available? And B, you mentioned the Minnesota laws are a little more strict, so if it is publicly available, do you think it would be a valuable resource to other states?
Absolutely. Yes to both of those, and we will make that available to you, Charles, and you can share it with the group.
Great, I very much appreciate that. Thank you. Matt?
Yeah, that's something we've done some work on. At the beginning, this was in 2013 when we first started with a behavioral health carve-out, we had our plan sharing some information just about who was being seen through their network with primary care providers, which was extremely positive. But it didn't last very long. It went about 6 months, and both providers who were receiving the information and the plan got very jittery about the legal risks involved, and I think 42 CFR Part 2 was connected to that because people move around, change primary care providers. We had some primary care providers saying, hey, I'm receiving sensitive information about somebody receiving a behavioral health service. Anyway, it all stopped after a few months because of those types of concerns, which I'm not even sure how real that was. It was all good information sharing for the purposes of trying to coordinate care better, but there was enough perceived legal risk there that it didn't continue. We've also worked with our health information exchange, but they are similarly nervous about accepting behavioral health information in their system. Our long-term goal is to be able to use the HIE to pull clinical measures out, to pull out clinical measures that we can use for things like shared savings and that type of thing. And so we've done a lot of work with them to that end, but that is a huge undertaking, and anybody who's worked with HIEs knows how complex that can get. And so that is very much a work in progress, and we're not very far along the road there.
Fair enough. One of the questions that we received from a participant is in terms of the role for managed care plans. And Matt, acknowledging Idaho's, you have the Idaho Behavioral Health Plan for especially mental health populations. I'm curious to hear more about any connection between your PCCM program and individuals. It's really a population question at that point. So I'm curious to learn if there's kind of bidirectional work, better connecting primary care in clinics where the individuals served by the Idaho Behavioral Health Plan would be receiving most of their care. And then in Minnesota, I'm curious to learn more just generally about the work that we've learned about today and the connection between the community mental health plans, or the community managed care plans, sorry. Matt?
We have done a little bit of work with our plan, and so we've got a single statewide plan, but we have done a little bit of work with our plan around that, and at one point we had convened a group of primary care providers and behavioral health providers with the idea of, and representatives from the plan and state staff, our primary care staff, to try and keep it moving forward and keep a little bit of a discussion going about behavioral health integration. We didn't get very far with it. I don't want to sound negative, but I think having a behavioral health carve-out is a natural silo that takes a lot of effort to overcome. We're not giving up on it. We're trying to do something with aligning incentives with the quality measures that we've selected and that kind of thing. But it's by no means easy. I think the best bet that we've seen is where you either have the primary care bringing somebody into their practice or have the behavioral health bringing in a primary care provider into their practice, which we've seen as well. But some of those behavioral health providers have really struggled with how that works as a business model for them. They don't understand the primary care end of things and really how to make that work in the same way that they understand their core competency with behavioral health. And so we've seen one or two clinics try that and then say, yeah, this isn't working for us after a few months. But there are some that have succeeded at it.
Thank you. Jennifer?
In Minnesota, I think we're very fortunate. We have numerous managed care organizations, including county-based purchasing plans in our state. We have 87 counties. And so the integration of care has happened at an MCO level, but also within the clinic. We have several large healthcare systems within our state that have had decades of success with integrated care models, our FQHCs, as well as now we are one of the demo states for the certified community behavioral health clinics. And so I think that the notion of the co-location, I think, has been very, very successful. I think now it really is about how do organizations come together without, or let me say this differently, for those who are not under those larger umbrellas of integrated care, how do they participate in these integrated care models without sort of losing their individual identity? And so that's where you're seeing more of our community mental health centers becoming certified as healthcare homes and bringing on primary care and dental within their organization, so they don't feel the necessity of sort of joining some of the larger integrated care models.
All right, thank you. And Kitty, do you have anything you'd like to add to this conversation?
Hi. So I think the MCO piece, we're certainly seeing integrated care products in states like Arizona and Florida, for instance, for the population with serious mental illness. And I think an increasing use of carved-in managed care for Medicaid in an effort to get at some of these integrated care issues. Kansas and Nebraska recently put some managed care contracts online. Tennessee has been carved in for quite some time. And we're also seeing MCO involvement in major system delivery reform efforts in terms of contracting with the CCOs in Oregon and in Washington as part of their accountable care model. So managed care organizations, states are working with managed care organizations on these issues most definitely. I think there's a lot of focus on measurement in those discussions and ensuring that there's an adequate array of physical and behavioral health measures, and also a lot of discussion at the state level around trying to capture those measures that represent integrated care, that get at care coordination, that are around follow-up and transfer of summary of care plans and things like that. So I think it's a challenge for states to really make sure that, and I think it's a work in progress, to make sure that those integrated care concepts are embedded in managed care through measurement. There's also, I think, some states that are pretty hands-on in terms of, again, describing what those services look like, what kind of holistic combination of services and professionals they'd like to see on their teams. There's just an increasing effort on behalf of state policymakers writing those contracts to, again, kind of embed that vision into those contracts, and then outside of the managed care contracts, be supporting the system and provider transformation in other ways that we've discussed here, learning collaboratives, resources, other levers that states have to impact the behavior of providers.
Thank you. So some of the conversation touched on another question that was asked in terms of changes to business model and the need for capital and infrastructure investment. So I'm curious, and Kitty, I didn't mean to close the first question off to you either, so please jump in any time that you want to add something. In terms of this question around the provider capacity and their ability to transform and change their business models as necessary. I'm curious if you both could talk just a little bit more about the engagement with the providers and the training that's happening at the state level to help them make these transitions, and then any conversation that you're able to share just in terms of the investment at the provider level and getting the provider buy-in and strategies to really help make the business case for them would be, I think, really interesting to hear. I forgot who I started with last time, but let's go back to Matt.
Sure. So one of the ways we thought about this was when we were building those PM amounts, how we got to the numbers that we eventually adopted was we built in some assumptions about funding either a care coordinator or kind of certainly not a psychiatrist or psychologist, but a mid-level clinician, behavioral health clinician, and we tried to build in enough funding there so that you could support that type of model in your clinic. And then we'd made a few other assumptions about physician time and that kind of thing. So we tried to support the business model in that way. I think we were reasonably successful in that. We've certainly seen a lot of people sit up and take notice and say, that looks like something I want to do, and we've seen a lot more people come into the higher tiers in our primary care program as they developed capacity to be able to do that. And so that was good. I think we still face some challenges. That you've got to build one claim system for behavioral health and another claim system for primary care. And so if you really want to be integrated, you've got to learn your way around two claim systems. That's not a challenge for bigger practices that work with a whole bunch of claim systems every day, but for some of the behavioral health providers that are really focused on a Medicaid population, they're used to working with a single claim system, and so they don't. That is a challenge for them, and it is a challenge for their billers, and so that's maybe an opportunity for the future that if our plan could get out and do some of that training, or if we had a directed effort with our MMIS, our Medicaid claim system, with some of those staff getting out and doing some training to the plan. the behavioral health plans providers, that might be a way to address it.
Thank you. Jennifer?
Sort of taking a different approach with our State Innovation Model Grant, with just the initiatives I talked about, practice transformation, practice facilitation, learning communities, and emerging professions, we spent over $11 million that went directly to providers to participate or have grant funding to meet the objectives under those RFPs. And so a significant amount of money has gone into building that infrastructure and acknowledging the need for that infrastructure to be able to successfully do this. Under a planning grant for the development of our health home model, we were able to bring in a consultant who actually spent over a year with many of our first implementers really thinking about their business model and how taking on that more integrated approach did require thinking about things differently, much more so out of a fee-for-service framework. And so there was a lot of hesitation on providers as it related to sort of this panel management and taking on a broad set of people with what they see as a very small PMPM when you're thinking about a community mental health center and being required to partake in all of those activities. $245 per member per month seems ridiculously low, while at the same time for primary care providers, many of them under a health care home model, it's a tiered payment, but the top tier is $67 per member per month. And so depending upon where the organization is at, that payment model is either very robust or completely insignificant. And so we still are challenged with supporting providers and ensuring there's a balance in the expectations in the delivery of these integrated care models, while still ensuring that there is some best practice required. One of the things that we did do in our state appropriation was ensure we had ongoing appropriation to annually support providers and continuing to build their capacity with professionals and practice transformation, and then grant-making opportunity to continue to build their IT infrastructure and utilization of patient registries and our partner portal in managing care.
Great, thank you. And Katie, I'm curious in your work if some of the lessons around administrative alignment that you've seen in other states might be appropriate to talk about here.
Sure. I think one of the things that we're seeing is states like New York and I mentioned Arizona taking a look at how they structure themselves internally so that they can better support providers and start to remove some of the barriers to care delivery. New York has done some really interesting work on aligning its payment so that people don't need to kind of knock on a variety of different doors in order to fulfill very different licensing requirements in order to deliver both physical and behavioral health care. And as I mentioned, Arizona has done some of this work as well. So I think there's some recognition that state administration needs to change also in response to the work that is going on in terms of system and provider transformation, that there are some hidden but very real costs to that are buried in licensing and regulation that speak to and kind of support old ways of doing business. So it's very interesting to see. It can be a pretty complex project and kind of mirrors the efforts that providers and systems need to go through to integrate themselves to do that work internally as well. But I think there's some administrative relief there for providers that can help move things along.
Great, thank you. So another one of the questions that we received from an audience member gets to the point that there's a lot of kind of jurisdictions at hand here. We have the national landscape. At the state level, you're implementing programs at the state level with the acknowledgement of regional variation. I'm really curious to learn more And Matt, I really found it interesting when you mentioned that you had the frontier part of the state where there was only the one provider. So I'm curious just to learn the lessons that came out of working in that, knowing that Minnesota also has some rural areas. How do you build systems or how do you build programs that fit the diverse needs of your state? Even I know that even states like Massachusetts or that some might feel are a little more urban. They also have the Berkshires, so I think that this really applies across the country. Jennifer, do you want to start?
Sure. I think we certainly have diverse landscape in Minnesota and have a frontier county as well. Much of our innovation is driven and designed at the community-based level. And so our provider community has always come together to ensure they've got the capacity to meet their needs. And so really what we've always tried to do is, under our SIM model and other reforms, is how do we create something that allows flexibility to meet the local landscape. I think one of the things that we have been fortunate in our state is that we are state supervised, county administered. So 87 different counties administering many of our Medicaid services. And so that administrative oversight is happening at the county level. They've got the capacity. They work effectively with our managed care organizations. The majority of our Medicaid is delivered through managed care. We only have a handful of folks that are still in fee-for-service. And so with the diverse number of managed care organizations, and in our state the requirement that they are nonprofit organizations, they drive innovation and the support of innovation through grant making and a variety of other mechanisms. Southern Prairie is an example, which is a collaborative with I believe 14 counties in southwest Minnesota, which have integrated their human service, public health, and primary care delivery within numerous communities there as a way of ensuring efficiencies and coordination for people. So just one example of that. And then in our frontier county, I think for them, they always articulate, they've always had a need to work collaboratively together and efficiently together. Otherwise, people don't have access to services. And so for us, it really is how do we as a Medicaid organization come behind and support really what is already happening in communities.
Great, thank you. And Matt, before you begin, maybe this is a good opportunity to kind of dive in a little deeper. You mentioned your telehealth or telepsychiatry work, so I'm really curious to hear more about that, considering that would be a strategy that I think states would pick up in a rural area.
Yeah, and we've definitely put some focus on the telepsych to try and promote that. We have one of our hospitals here that has put a lot of effort into telepsychiatry, and they've got remote locations in some extremely rural communities, and so that's been positive. I think the challenge with that is that we have our way of doing things, but every commercial payer has their own way of doing things as well, and so it's just not consistent, and nobody knows how to really bill a telepsych encounter in a way that will work for everybody. And so that I think has been challenging. Even though we even opened it up so that you could bill you could bill an encounter rate through an FQHC under telehealth, and we still haven't seen it take off. So that's been challenging. I think what's been more successful is Jennifer speaking a little bit about Minnesota and how the efforts the plans do. We've kind of taken some of that on, I guess, at a state level, and so getting our representatives out there and just getting face to face with the providers, I think has been one of the most successful efforts. As we try to communicate what we're doing and being able to make connections. Those staff really know primary care at a pretty deep level in Idaho, and so the providers know that they can call them up and that they will answer their questions or even connect them to another provider who might be working on some of the same challenges. So I think that's probably the most successful strategy.
Thank you. Kitty, any lessons from the field that you'd like to share?
I don't think so. I don't think I have anything to add, but thank you.
Yep, great. And talking a little bit more about just the national landscape in terms of, I'm curious to hear about any work, in your work with CMS and getting these programs approved, and the work with SAMHSA perhaps, any engagement with SAMHSA. I'm just curious, are there any lessons that you care to share based on your engagement with federal partners or advice that you have as other states take on similar initiatives and getting these types of models through regulatory review?
This is Matt, and I think the biggest challenge that we faced in our review with CMS was, when they were looking at our provider agreement modifications, that kind of took a long time. They were looking at them, more in the context of a managed care contract, which PCCM is managed care, but the way we're using it is pretty significantly different than what you'd expect to see in a state that has got a lot more managed care infrastructure than Idaho. So there was a little bit of a challenge as we worked through that with them and kind of went back and forth on the review process for our provider agreements that enabled us to do this type of thing. So I think the takeaway would be expect to spend some time educating on how things are working in your state, and expect to spend some time going through a little bit of a review process there.
And in Minnesota, I think as it relates to our health home model, we certainly had a really heavy lift as it related to the duplication of services. We were fortunate to have technical assistance. And I think one of the things is really heeding their advice. And we spent a very long time cataloging and demonstrating where the health home model would fit and either take the place of or wrap around other service models. Another piece that we had to spend a concerted amount of time with CMS on is how there wasn't a duplication of payment through our managed care organizations. We did not change our capitation rate for managed care plans as it relates to the removal of administrative dollars that might have otherwise been paying for care coordination, but instead worked very closely with all of our managed care organization weekly, as a matter of fact, for over 6 months to really demonstrate and create workflows and roles and responsibilities documents, and then later through contract negotiation and contract requirements, how all of these services intersect with one another.
Great, thank you. And that's really actually a really good lead into a couple of questions that I had in terms of health homes, because I find it interesting, especially that Idaho, started with, or maybe not started with, but health home was a component in the middle of the timeline that Matt shared. So I'm curious to hear from both of you the pros and, if you're willing to share them, the cons of the health home model and the opportunities that it prevented your state. And Matt, if you're willing, to hear a little bit more about why you moved away from that authority in favor of the PCCM. So Jennifer, let's start in Minnesota.
I think for Minnesota, our Medicaid accountable care organization model, our integrated health partnership, is really at the forefront of our reform activities, and we have a waiver to be able to, or actually a state plan amendment, to be able to do that. And that really is the future of our value-based payment arrangements with providers. And so instead, for us, we use the health home opportunity in a smaller way, and really looking at who within our Medicaid population had the poorest outcomes and where we had an opportunity to do things in a more preventative way. And so taking on really what are a lot of restrictions and expectations on the delivery of that service model. And so I don't know that we would have ever utilized it in the way we do our patient-centered medical home model, and certainly wouldn't have as we look at some of our broader health reform initiatives. But it's worked very well within this more confined population of people.
Great. Matt?
Yeah, and I kind of have a similar answer, but from a different direction, I guess. So we use the health homes and it was very helpful as we implemented that. It was a big lift, but to get that focus and to get that opportunity out there, and certainly the enhanced funding helped a little bit to be able to get that off the ground and get a budget approval for it and keep it moving along. One of the things that we found challenging was collecting the data, and that certainly informed our shift towards using claims-based measures and also in trying to build up the capacity in our health information exchange because our first round of data collection, let's just say, it did not go well. There were a lot of inconsistencies across different clinics, and it took a lot of work to try and round that all up and make sure people were reporting data consistently. So why we moved away from it was really we saw that we had a path towards more of a comprehensive kind of model through PCCM, and we certainly could have maintained the health home structure, and it was a good one, but we saw some advantage in moving to PCCM and being able to build on that for future developments. I know which is kind of what we're working on now with our regional care organization under the same type of authority. So that's kind of why we moved away from it and some of the advantages and disadvantages that we saw with it.
Great, thank you. So this would be a last call for folks who want to ask some questions. We are running up to the top of the hour. We do have one more question left in the queue, so we might be ending a little early, but we don't have to if there's still some questions out there, so now would be the time. So I'm not familiar with the efforts in this question, so I'm hoping that other folks on the call may be, but the question is, are there any efforts to promote community-based collective thrust efforts to ameliorate the locally significant determinants of unstable health? And the examples here were teenage pregnancy and early childhood obesity, but pertaining to the integration work, I'm curious to learn if there's any of these efforts underway in Idaho or Minnesota, or the types of, if not, then we can extend this question into maybe partnerships beyond the health system and thinking about community support providers and social service providers.
I certainly can begin. We don't have any formal efforts in the development of the collective trust. However, it is certainly something of interest to us. And it pops up, and we certainly have had internal researchers do some work on it, but really haven't been able to put any concerted effort towards that. And then I think for us, we have always driven to ensure the integration of a variety of different provider types in the delivery of services and the ability to meet the needs of individuals and address social determinants of health. And so I think our SIM model has really been, as we're closing our fourth year, very successful in really trying to demonstrate the varying perspectives and the important role each play in meeting the triple aim. And so I just am very positive that this will continue in our state if we continue to sustain the integrated relationships developed and further supported under SIM.
Thank you. And Matt?
We don't really have anything specific to collective thrust efforts, but it is something we're thinking about, and under our SIM grant, we've established kind of medical neighborhoods or regional organizations that work in conjunction with the public health districts to try and have more of a community focus around that. And then we're looking at leveraging that as we move into more of an accountable care type environment to have some of the incentive funds that will end up flowing to our accountable care organizations go towards addressing some of those social determinant of health type of things. But we're not very far along yet.
Thank you. Kitty, anything that you'd like to add based on the research in terms of how states are bringing in social support services as part of this work?
I'm not familiar with state efforts around the Collective Thrust Initiative in particular, although I think there are conversations about how to kind of make the case for integrated care for kids. Certainly there's a recognition that it's a good model, and a lot of the behavioral health issues that become more expensive over time start to occur in youth and teenage years in terms of teenage pregnancy, substance use disorders, major mental illness. I think states struggle sometimes to make the business case. Certainly there's a strong and obvious business case to be made for the adult population whose costs are borne by the Medicaid program. For kids, as this question indicates, a lot of these issues are getting realized in partnerships with public health, but I think we will start to see increasingly that there's a move to make sure that there's integrated care for kids as well to start to address some of these issues. I think just right now the conversation sometimes can be around the business case and the return on investment for kids, which is a little bit more challenging to make.
Well, thank you. So that is the last question. So with that, I do have one more, a very NASHP type question that I think I'll close with. So if we could just go around the room to the speakers, and I'm really curious to hear your perspective. You can answer one of two questions. Either A, if you could start over and do it again, what would be the thing that you do differently? Or B, what is the most important lesson that you've learned in this work? If you want to answer both, go ahead. But if you only want to take one, that's absolutely fine too. So I think we'll start with Matt and then go to Jennifer, and then Kitty, I will give you any closing thoughts that you'd like to add.
I think if we had to start over, I think we really underestimated the level of challenge that we would have in kind of bringing along behavioral health integration. We kind of didn't know what we didn't know when we started. And so I think if we had had a little more time and effort and resources put into thinking it through and designing it in a little more thoughtful way, we would have probably had some better results. Hindsight's always 20/20, and it's easy to think about it looking back, and kind of not fair to the people that designed it in a way too. But if I had to do it all over again, that's what I would do.
Sure. Thank you. Jennifer?
I think some of the important lessons learned are things that I've articulated already, but really that importance of managing the relationships, expectations, and understanding of the overall objectives, and allowing for that flexibility in getting there in different ways. Although we're very prescriptive in some ways, it is that flexibility in how the services are delivered that I think is very important in terms of getting buy-in. We started with and continue to work with a large group of stakeholders in the advisory, both in the development and the ongoing implementation of that. So really keeping your stakeholders, which included for us advocates, associations, and the providers, both community-based, large system-based, mental health, and primary care at the table, I think was imperative and a large lesson learned.
Great, thank you. And Kitty, any last words of wisdom for the participants?
I would just concur that stakeholder engagement is critical, both based on my work in a state and also in working with other states around the country. And I think Idaho and Minnesota are two states that have done a really great and interesting job of engaging stakeholders. So I would concur that early and often with stakeholder engagement creates a better product.
Thank you. Well, I just cannot thank everybody enough again. We definitely appreciate your time and all of the information that you shared with the audience today. For the folks still on the webinar, I highly encourage everyone to fill out the evaluation. You will be automatically redirected to the evaluation once I close the webinar. And it really is important to our work. We really do appreciate the time you take not only to attend these, but also to fill out these evaluations. And please let us know how we can make these better for you in the future, and additional topics that you would like to see us cover. So with that, I do have 4 o'clock Eastern Daylight Time. So I will let everybody get back to their day. Thank you again. Thank you to the Commonwealth Fund for making this work possible, and thank you so much to our speakers who did a really great job today. Thank you.